If you had to rate it on a scale of 1 to 10, how much would you rate it? Could you answer that?
I'd say 8.
About an 8.
Yeah.
Do you sometimes get a 10?
Yeah.
People think about akathisia as a historical problem that they don't have to worry about anymore. But we're doing better than we were, no doubt about it, with these side effects. But we're not, but there's still a problem. I mean, there's still a significant clinical problem.
It wasn't like a muscular thing, as though I had twitches or stiffness or anything like that. It's just that I couldn't feel comfortable. Mm-hmm. It was sort of
Akathisia has two components to it. One is a subjective component of inner restlessness that often is in the large muscles in the legs.
Like I just couldn't sit still.
When it gets beyond the subjective component, then objectively it begins to look like fidgeting.
And just had to keep moving around.
But at the upper end of the spectrum, people look extremely agitated.
I was just pacing around back and forth, and I didn't know how to help myself, and I was begging for help.
What was dramatic when I saw him was he couldn't sit. It was, an old-fashioned akathisia description. He could not sit in my office. I used to walk with him on the corridor. So talk about privacy in hospitals and trying to get interviews. We're walking, getting history. I'm walking behind him.
It was like the energy in the muscle wanted to break out of my skin. And
by the time people are describing themselves as jumping out of their skin, that is highly suggestive of akathisia. But I think if you wait until the person tells you that they're jumping out of their skin, then you'll have missed a lot of akathisia, much of which is consequential below that level. It can be pretty disruptive below the jumping out of your skin level.
We've learned well through schizophrenia to diagnose cogwheeling, tremors, stiffness. You can see it. Akathisia somehow is lumped together with agitation, motoric, activity, and somehow is seen as part of the illness, so it's even harder to disentangle.
I would always question whether it was the medication or was it something about me that wasn't right. And I'd always find myself kind of going back and forth between that. And so what it created was kind of a confusion.
I just found out it was akathisia from Dr. Allen. He called me up and asked me if I had it. He said, it's something that makes you feel like you're jumping out of your skin. And I said, no, I haven't got that, because I thought he meant anxiety. And then the night after he called, I went to bed, and I forgot to take my quinine sulfate, and I just realized that's what he's talking about. I feel like jumping out of my skin. So I called him back, and we talked over the phone, and he said he thought I had it.
For clinicians, they're often waiting for the patient to spontaneously report the effect, which means that the patient has to have some words for it.
He said the key to whether one has it or not is the buildup in the muscles before the, just when the muscle's given, you have to thrust your, just jump.
Roberta had no language, for conveying this thing, and had so many odd experiences. I think in the course of her illness that she didn't know which column to put this in until I attached a word to it.
Parkinsonism is a very objective phenomenon, and so it's easier to detect. Akathisia is not, and you do have to pay attention to subjective components of the diagnosis. But I think most people agree that the prevalences are pretty straightforward. There are probably about a quarter of patients with traditional neuroleptics, probably about half that, which is about 10 to 15% with the atypicals. The interesting thing to me is that it's not 0%, and it's not 1%, and it's not even 5%. It's more than that. And that's what I mean when I say it's common.
One of the problems is that people often don't look for it very aggressively. And so in studies that have compared routine clinical care with research examinations of the same patients, it's turned out that clinicians were picking up less than half of the extrapyramidal side effects. And akathisia also has a lot to do with people not taking their medicines. Van Putten, looking at people who were comfortable taking their medications and other people who didn't want to take their medications, found that the thing that stood out between the two groups was the presence of akathisia.
He got tired of all the side effects and he refused to take anything. He just point blank said, I'm tired of it, I'm not taking any. And he went off for a month or two, and it was very hard to be with without the medications, very hard. And
but it was kind of worth stopping just to. That was the point that I was getting sick every day. Actually, it was a little bit after that.
Mm-hmm. But it allowed Dr. DeBella to add one pill at a time back in, one kind. So it really wasn't all bad to do that.
And through that process, we've actually eliminated some of his medications. And when we restart him, he does okay, maybe on one or two. Now he's at the point where he's only on 2 medications, doing fairly well. He graduated recently from a high school special education program.
In addition to noncompliance, the other major problem is suicide risk. It's associated with increased suicide risk, suicidality. You know, if you think about it, sometimes it's as straightforward as someone feels like they can't sit still, they've got to move, they've got to jump out of their skin, so they go to the roof and they jump.
I had a very hard time going to sleep. You know, I just wanted to jump out of my skin, you know.
It may not necessarily be that they wanted to kill themselves, but that they don't know what to do.
Was suicidal, you know.
Especially if they don't realize that it's drug-related.
San Francisco, visiting my brother and contemplating.
Or that it's something they can do something about.
Appointment, walking down to the bay and contemplating jumping into the bay and, you know, just starting to swim and, you know, I just felt edgy, you know, all the time. And
they suddenly have this extreme feeling of uncomfortableness that they've never experienced before.
It was a nightmare.
Akathisia has led to suicide, suicidal attempts, homicide, homicidal attempts, impulsivity of just trying to do something, you know, and they may not fit into either the suicide or homicide category, something in between, but with dangerous consequences. So, I mean, those are the consequences of this particular side effect. Are you going to stick with medicines for the long term? You know, if we are giving something to them without prepping them. If you prep patients, sometimes they will live with certain types of side effects, as long as it passes. If it's transient, that's great. If it isn't, they don't want your second good idea.
I think the key issue with differentiating akathisia from agitation and from mania and from psychosis in particular, and from other states where there's agitation, is to take agitation away as your primary consideration and to focus on what differentiates mania. And I think dig-fast criteria is what you have to do to diagnose mania versus akathisia. And the other thing that is important is to avoid using the phrase activation, because I don't know what that means. You often hear people say, the patient's activated on this SRI or activated on this antipsychotic, and they just kind of leave it at that. But to me, it doesn't add any information. I still don't know what I'm dealing with. And so I think we have to think about educating people to take the phrase activation and take it one step further and make a diagnostic assessment. And some of those patients are going to have akathisia.
It lasted, I'd say, probably at least 2 days.
Now, how is this different from the manic moving around a lot?
Well, when you're manic, you feel like you're in a high, you know, grandeur. This way, I didn't feel like that. My head was not racing. I didn't have any racing thoughts or anything like that. It was, I couldn't stop just walking or whatever I had to do so I could survive, literally.
It felt more like a physical sense of needing to walk.
Yes, definitely. It was definitely all physical.
Yeah, which is a little different from mania where you have more of a psychological.
And I had a hard time trying to explain what was happening to myself. And
people with akathisia really talk about it in this not me kind of way.
It wouldn't stop.
I don't mean to be doing this, I'd like to quit. So it's the agitated person is pacing because they're agitated, and they'll tell you that in various ways. But the person with akathisia may tell you, look, I just can't sit still here. I just, I feel terrible, and I gotta do this.
I could not.
But it's a not self
Still,
kind
I
of
could not
phenomenon with
sit.
them.
I could not sleep. The only thing that I could do was move.
Distinguishing
I would
between
literally
anxiety
go through my house,
and akathisia can be very
walk
difficult.
Constantly for hours. I couldn't stop.
I think what you need to ask the patient is, are they worried about things, or do they have concerns about things? And typically, if they're feeling akathisia, then they're not having worries or concerns about things, except they feel like they can't sit still. I think the first thing I try to do is assess whether they have been able to tolerate lower doses as far as efficacy and side effects. So if they've been on a lower dose but they haven't gotten good efficacy, even though they were able to tolerate it, well, that's not an acceptable option. But if they are able to tolerate a lower dose, that would be my first option.
So that's one level of decision making. A second would be switching. And I think clozapine, quetiapine are probably one extreme for almost lack of akathisia. You could almost argue that these drugs may be the choice. If someone had akathisia, you might almost want to choose one of these two. Clozapine is a little trickier to use as a first-line agent. It's kind of reserved end of the line, almost schizophrenia or bipolar, but it's end of the line. Amongst these newer drugs, there's, I think, a different propensity for akathisia. It may not be reflected in the package insert, but certainly we see it clinically.
I apologized to him. I said, I'm having a hard time sitting still. I'm not really in control of what I'm doing. I'm just pacing. And I'm really nervous. I'm upset. I feel that, I'm not getting anywhere. And he told me that he may have a drug that would help me.
And actually, on the second, maybe the third visit, I could recognize him, literally. Because, from this not unkempt, maybe that's too harsh a word, but, sort of minimally groomed sort of person. Here was someone, well-groomed, sitting there. I thought he was a staff member sitting outside in the waiting room. It changed completely.
I still have depression, but I don't have the uncontrollable body motions. I don't have the uncontrollable thoughts or the hallucinations or any of the other things that were bothering me.
So switching, that's an option. And a third option is to continue treatment, but to treat the side effect now, which for many patients who might already be on more medicines than they think they need, adding yet another drug to treat a side effect is a trick and a half.
But in some patients where you've tried everything else and this is the only drug that works and this is the only dose that works, then you got to give them the propranolol or Inderal. And that can work, though you do run some side effect risks with that. In males in particular, impotence, and in general, an increase in cholesterol to some extent. There's often a misconception that Inderal or propranolol can cause depression, and so we shouldn't be giving it to mood disorder patients, but actually the risk of depression with it is quite low, and I think it probably was overblown. Recent studies suggest it's probably low. Any other muscular side effects that you've had that you think we need to mention?
My legs were not connecting very well, and I couldn't use them well. This was about at least 10 years ago.
Antipsychotics in general are being used more because they're less toxic than they used to be.
It was one of the traditional neuroleptics.
Yeah.
But I've noticed
But the problem is that people have thought that the atypicals have so few extrapyramidal symptoms that they've just paid less attention to them, and particularly akathisia.
You have them with some of the newer ones.
Akathisia has been lumped with EPS, and not everyone agrees, even perhaps from a mechanism perspective in the brain, that it should be. But even if that was just an academic quibbling point, one might argue that akathisia is a very troubling side effect.
I have to move or do things and do things.
I think it is an extrapyramidal syndrome.
Whatever normal is, but
Clinically, does it matter?
when I can't.
I think
sleep,
it matters
when
in
I-
the sense that clinicians use the phrase EPS or extrapyramidal symptoms. Pharmaceutical companies use the phrase EPS. They market around EPS. There's a lot of back and forth about EPS. And so if you're going to use the phrase, then it matters, because if you misidentify EPS as just Parkinsonism, then people will miss akathisia. So if they believe that a drug doesn't have EPS because it doesn't cause Parkinsonism, and yet all their patients get akathisia, which they don't diagnose and don't treat, then you make patients worse. So I think in that sense it certainly matters.